on to the bacillary dysentery, shigellosis. So here you will have fever in bacillary dysentery, shigellosis. You will have the fever, have the dysentery, not the diarrhea. Here the dysentery, mostly the colon is involved here. Whereas in the cholera, it is a small intestinal involvement. Here it is a large intestinal involvement. So there will be some formed stools will be here. So abdominal pain, fever, dysentery are there in the shigellosis. It's the gram-negative rods invade the colonic mucosa. You have the 4 types. So Shigella, Sony, Flexneri, Boydi, and the dysentery. So the Boydi is available, is common in Indian, Sony all over the world, dysentery in some areas, and the Flexneri also in the tropics. So in India, we have all these 4, Sony, Boydi, Flexneri, and dysentery. The organism only infects the humans. Again, it is facilitated by its low infecting dose of around 10 organisms. Even the 10 organisms are sufficient to cause the infection. Occur via contaminated food or the flies. Transmission by the unwashed hands after the defecation. So again, hand hygiene is very important, food hygiene is important, and sanitation hygiene is very important. Outbreaks occur in the mental hospitals, residential schools, and other closed institutions after wars and the natural catastrophes which bring crowding and poor sanitation in their wake. So here in our India, we have a lot of the residential schools and the closed institutions. So especially welfare hostels. So it's a very common bacillary dysentery or cholera. Shigella soni is a mild infection, Flexneri, severe infections, dysentery, fulminating and cause death within 48 hours. Even today, a lot of the people are dying because of this gastroenteritis, because of the shigellosis, or maybe because of the cholera. That is the most unfortunate thing. Even today, in this era, a lot of the people are dying with gastroenteritis or these ulcers. So this is because of these poor hygienes. So colic abdominal pain here, the tenesmus, stools are small, unlike in Vibrio cholera, where there is very high volume of the stools, maybe liters, 10 liters, 15 liters a day. Here the stools are very small, contain the blood and the purulent exudate with a little fecal material. Fever, dehydration and weakness, tenderness over the colon, and the complications, arthritis, sometimes IBS. These are also very common here. Reactive arthritis mostly. Salmonella enterocolitis, disease due to the enterotoxigenic E. coli, Campylobacter, Yersinia enterocolitica, amoebic dysentery, and ulcerative colitis. So these are the common DDs for the postgraduate. So salmonella enterocolitis like case or typhoid fever. Okay, E. coli. So enterotoxigenic, enteroinvasive E. coli. Amoebic dysentery is a very common here, and ulcerative colitis. So this is the differences between amoebic dysentery and bacillary dysentery. Nature of the lesion, necrotic due to the proteolytic ferment is amoebic, whereas suppurative due to the diffusible toxin is the bacillary dysentery. Depth of the ulcer, amoebic very deep, where the shallow bacillary. Margin of the ulcer ragged and undermined, whereas uniform and sharp margins is bacillary dysentery. Intervening mucosa is normal in amoebic, whereas inflamed in bacillary. Organism Entamoeba histolytica, here Shigella shigi or Flexneri or Boydi or Sony. Necrosis, pycnotic body and mouse-eaten cells in amoebic dysentery. Cariolysis and ghost cells in the ring nucleus. Liver abscess are common in amoebic, or amoebic liver abscesses. In bacillary, no. Sometimes no pyogenic liver abscess. Cellular response, mononuclear, here the polymorphs. So there is a clear differences between amoebic dysentery and bacillary dysentery. Onset, very slow in amoebic dysentery, whereas bacillary dysentery very fast. Acute. Fever, absent, whereas bacillary dysentery present. Toxicity, the toxic bacillary dysentery because of acute presentation with fever, febrile, colic, etc. Abdominal tenderness is a localized in amoebic dysentery, whereas generalized in bacillary dysentery. Tenesmus is usually absent in amoebic, whereas positive in bacillary dysentery. Number about 6 to 8 motions per day, but more than the 10 motions per day in bacillary dysentery. Relatively copious and small, order offensive in amoebic, odorless in bacillary, dark red in amoebic, bright red in bacillary dysentery, mostly the brown in amoebic, whereas the bright red in bacillary dysentery. Blood and mucus mixed with the feces. Here the blood and mucus, no feces in bacillary dysentery. That is the reason it is bright red. Reaction is acidic in amoebic, alkaline in bacillary. Consistency not adherent to the container, adherent to the bottom of the container. Cellularity is very poor in amoebic dysentery, very high, polymorphs, etc. RBC in clumps, reddish yellow in the color. They are discrete and bright red in color. Pus cells scanty, there is a numerous in bacillary dysentery. Macrophages very few in amoebic, large. Eosinophils present in amoebic. Pycnotic bodies very common in amoebic. Ghost cells are numerous in bacillary dysentery, whereas there are trophozoites and many motiles. Trophozoites are present in amoebic dysentery. And charcoal laden crystals, etc. They may be present in amoebic dysentery. So management, oral rehydration therapy. So these two are very, very important to rule out the amoebic dysentery and the bacillary dysentery. All these points will clinch you both clinically and as well as the microscopically. So oral rehydration therapy, IV replacement of water and alkalis if diarrhea is very severe. Antibiotics, here the ciprofloxacin, quinolines, chloroquinolines, ciprofloxacin 500 milligrams 12th hourly for about 3 to 5 days. Prevention of the fecal contamination of the food and the milk, isolation of the cases, hand washing, these are very important. Essentials of the diagnosis, diarrhea often with the blood and the mucus, crampy abdominal pain and systemic toxicity, WBC in the stools, organism isolate and the stool culture. So thank you very much for your attention.